Madam, we are live now on YouTube and our platform Shield Connect. So good evening, doctors and all the participants. I, Shuman, on behalf of Shield Healthcare, welcoming you all in today's session on bacterial vaginosis, and our guest speaker is Dr. Bindu Rohatgi, madam. Before moving into the session, let's have a look on our knowledge sharing platform, that is Shield Connect. Here you can find all the related information on obstetrics and gynecology in Shield Connect. Here, this is the tab. Here you can find all the information on various topics, and the topics are written by many eminent doctors across India. And these are the awareness kind of blog. Here you can find all the related information related to menopause or GDM or immune or many other things. And the most important thing is our key opinion leader. So almost 1,000 doctors across India are currently supporting us this knowledge sharing initiative of Shield Healthcare. So now it's time to start the session with Madam, and it's our honor to introduce Madam. And first of all, I would like to convey our sincere thanks to Dr. Bindu Rohatgi, Madam, for her valuable time on our platform Shield Connect. And Madam did her MBBS and MS from GSDM Medical College, Kanpur. She is a certified obstetric sonographer, trained in advanced laparoscopy and hysteroscopy, fellow Donald School of Obstetrics, DIPSI certified obstetrician, and IOTA certified sonographer. In terms of experience, Madam has a vast experience in the field of obstetrics and gynecology for more than almost 30 years of experience. She was honorary professor obstetrics and gynecology, JB Roy State Hospital. She was attached with Lohiya Matri Seva Sadan from 1995 to 2007, and Matri Mongol Pratishthan Hospital up to 2018, and she was the consultant at Rahmat Hospital 2003 to 17. In terms of awards and honors, Madam had received many awards and honors. I've just mentioned over here a few of it. She was the recipient of Ayush Ratna Award, Best Teacher of JB Roy Institute Award in 2017, and renal disease in fetus paper presented. She had already presented in ISEOG. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, once again for your valuable time on Shield Connect, and over to you for further proceedings. Thank you very much.
Good evening to all. I am just trying to share my screen. So today we are going to discuss a very important topic that is very much.
We'll screen it. Slides.
Yeah. So that is a very important topic in our day-to-day practice, and we see many patients, and the patients really need a good doctor and clinician to be treated to get rid of this chronic problem. So what now we will discuss why the bacterial vaginosis happen. To know that, we have to must know the normal vaginal flora. So we know there are many common cells in our bodies. Lactobacilli and the candid are the two main common cells that are there in the vagina, and because of the vaginal healthy environment, because of the vaginal acidity. So these two are the normal commensals, and they form the bulk of the vaginal flora in a female body. So why these are the ecosystem of the vagina is important. As we know, vagina is an open organ. It is connected one side to the uterus and other side to the environment. So, and it is a coupling organ. So it is an open organ. So thereby, what is happening to keep it healthy? Why? Because any infection in the vagina can ascend up to the uterus, into the peritoneum, to the tubes, everywhere. So the blood stream leading to septicemia. So the main hormone of the female hormone in the reproductive year is estrogen. What is the function of estrogen? Estrogen increases the glycogen uptake of the cell in the vagina, that leads to, that is by the lactobacillus, the glycogen is being changed into the lactic acid, and that in turn changes the vaginal pH into the acidic medium. This acidic medium again help in regrowth of the lactobacillus and keep the vaginal environment healthy. So whenever there is inhibition of this production of lactic acid, or there is disruption in the vaginal normal environment, then what is happening? There would be growth of the pathogenic, this gentle ecosystem will be disturbed, and there will be growth of the bacteria. Those are harmful to the vagina. So the vaginal flora main organism is lactobacilli, that is acidogenic and bacterial. So as we have discussed, the normal vaginal flora consists of lactobacillus, that it turns lead to production of lactic acid. Lactic acid is turn produce the hydrogen peroxide that keeps the vaginal environment acidic, and it helps to prevent many infections as HIV as well as other STDs, and keep the vaginal environment healthy. So now, what is bacterial vaginosis? The most common cause of the bacterial vaginosis is the growth of the unhealthy bacteria. So what is happening here? There is change in the type of the bacteria found because of the some factor. Those are the risk factor, or those are the premonitory factors that we are going to discuss one by one, and that is leads to what is happening. There is abnormal vaginal odor and the discharge. That indicates the first, that is a first indication of the infection in the vagina. So when there is bacterial vaginosis, this healthy lactobacillus is being replaced by the other bacteria. Most common of them is Gardnerella vaginalis. So now, what are the risk factors for the vaginal infection? The risk factor for the vaginal infection are, first on the foremost is poor personal hygiene. Second is the other factor, that is metabolic disorders, obesity, diabetes, excessive use of the soap, excessive use of the douches, excessive use of the chemicals on the vagina, then with wearing of too tight clothes and synthetic clothes, then use of the antibiotics, then hormonal contraceptive. Sometimes we can see there is, if there is the STD in the partner, or change in the sexual partner, or multiple sex partners, can also lead to development of this bacterial vaginosis. Any disturbed environment that is seen after pregnancy, childbirth, menopause, abortions, that leads, or IUCD insertion, can lead to bacterial vaginosis. Smoking and stress, this is the another factors, and poor nutrition and inadequate sleeps are also being attributed to the poor vaginal hygiene, leading to bacterial vaginosis, as well as recurrent urinary tract infections sometimes can also lead to the vaginal bacterial infection. So as we have discussed, these were the few risk factors. So though we can very well correlate with multiple sex partner or sexual relationship with new partner, but most of this time it is being seen that this risk factor might be related, but they are not absolute factor to a lady to have the bacterial infection. There are other factor also. A lady that might not give any history of the sexual intercourse can even suffer from the bacterial vaginosis. So multiple sex partner and recent change in the sexual partner also one of the most common factor that is being seen, and because of the immunological factor also. So why we are so much worried about the bacterial vaginosis? Why this is so serious a condition that we are so much worried? Yes, really it is a serious condition. How it, if it is happening in an obstetric patient, what is going to happen? There are more chances of the abortions in first trimester. In second trimester, there are chances of preterm birth, preterm premature rupture of the membrane, postpartum endometritis, and chorioamnionitis in pregnancy, while in gynecological cases, they can lead to urinary tract infection, recurrent UTIs, post-abortal sepsis, PIDs, peritonitis, post-hysterectomy vaginal cuff infections, infertility due to the salpingitis, ascending infection leading to tubal infection, that is salpingitis. Then there can be patient become more prone for the STDs. Those can be bacterial, protozoal, or even viral. That is being seen. Herpes simplex and HPV and HIV infections are more common in patients who give history of the recurrent vaginal infections or the other recurrent infections that happens particularly in few females more often than others. Now, though it is a very important disease and we have to treat it, but sometimes it is very much poorly understood. Why? Because one thing is we don't know what is the etiology. Though some factors might be associated, but etiology is not common. It can even happen in a patient with some distant infection in the body that can lead to immunosuppression and can lead to vaginal bacterial vaginosis. And there can, because microbiology is very much inconsistent. There are so many microorganisms that are commensals in the vagina. Any of that can lead to the infection. Then third is diagnostic difficulty, where it is very difficult to diagnose, to find out what is a different sort of infection. And sometimes 2 or 3 type of infections can be together, and that is very difficult to diagnose them properly. Then there is inconsistent response to antibiotic in some time. Because why? Because in postmenopausal or very young females, there might be less, because vagina is a less vascular organ. Sometimes there can be inconsistent response to the antibiotic, and that can lead to failure of the treatment. There is non-compliance of the patient that can lead to recurrent infections. And sometimes one medicine can work nicely for one patient, but sometimes some patients has become so resistant that they have got the inconsistent outcome. So, as we have already discussed in earlier slides, why we are worried about the bacterial vaginosis in pregnancy? Because in pregnancy, there are the many abortions can be related due to the vaginal infections. Secondly, they can lead to PPROM, chorioamnionitis, and preterm labor. And after the childbirth, they can lead to the postpartum uterine infection or puerperal sepsis. So that's why pregnant women with a history of the premature labor or any other complication must be tested at least one for the bacterial vaginosis. And very simple clinical examination per speculum can give us idea along with the wave test. So what can happen in a pregnant lady? There can be in the pregnant lady, as we have again, we will repeat this, that because it is so important, because BV can lead to first trimester abortion as well as second trimester miscarriages and preterm labor. So positive, if the bacterial vaginosis is positive, they should be given treatment with metronidazole. And now that metronidazole is being advised as safe during pregnancy by CTC. So we should give pregnant ladies, we should not avoid giving them medicine. Rather than we should ask them, we should just promote to take the medicine to be treated for the bacterial vaginosis. Now, we will just go through what is Gardnerella vaginitis. Gardnerella vaginitis is again a commensal, but it is present in very, very small amount in the, it may make a very small fraction of the bacterial or commensal environment in the vagina. But what happens sometimes, if their vaginal pH is disturbed, or if there is some bacterial infection, some immunocompromised state comes, this Gardnerella vaginitis can become active, and it is supposed to be the most important causative organ of the bacterial vaginosis. So what is it? It is a gram variable staining rod. Why? Because it might sometimes look gram positive, sometimes look gram negative because of its thin wall. It is an anaerobic rod-shaped bacteria, and this is a cocobacilli. This is totally non-motile, and this gives a specific odor because of the anaerobic nature of its own, and it is a very typical odor of the bacterial vaginosis. It is being told by our teachers, if you see a bacterial vaginosis patient, you will remember this smell for your whole life. Especially this smell can be felt in patients with the advanced CAs, that is the same smell of the Gardnerella vaginitis. So Gardnerella vaginitis can grow as small colonies in blood agar medium, and that can be cultured very easily because it is a very fast growing cocobacilli. And it can not even separate it from the vagina. It can separate it from the cultures as well as from blood, urine, and pharynx. So as we have discussed, it's a gram variable, non-motile, and so many under microscope, so many organisms can be seen in different colors. They can be blue, they can be pink. So they are metachromatic. And because of their adhesive nature, because of their nature of the fast growing, they are so fast growing, they just wrap up the cells, epithelial cells, and that cell is been known as glue cell. That is a diagnostic of bacterial vaginosis. So CDC has advised that gram staining is very, very important to diagnose the glue cell. And as we very well see, there are multiple colorful cell that is being wrapped by the cocobacilli, is looking somewhere pink, somewhere blue. So it is gram variable stain that is a pathognomonic feature of the Gardnerella vaginalis. And again, we have discussed that this growth is being culture is being done on the blood agar medium, that is a rabbit blood agar. So now that was about the organism. Now, how would patient comes to us? The patient comes to us with the symptoms. And if we are clinically expert, if we are thinking about this disease, then only we can diagnose. Because lower abdominal pain, most of the patient, first thing, they don't have any symptom. That is the foremost thing we must understand. 50% of the women, those are not been having any symptom. They have come for something else, say UTI or something else for infertility. And by chance, accidentally, we find, oh, it is bacterial vaginosis. So one thing is that patient is not aware of her infection. Secondly, in some cases, there is an unpleasant fishy vaginal odor, and that increases while being together with the partner, and that is the sometimes first thing that brings patient to the doctor. And patient gave a typical history of a thin gray, white, or green discharge. There is vaginal itching, there is vaginal discharges, copious discharges are there that is stain the panties and the thighs of the patient. There is dysuria, and there the symptoms increases after the intercourse. So these are the few symptoms. And sometimes patient may complain of lower abdominal pain because of the subtle infection, because of the PID, because of the urinary infection. Patient is complaining of lower abdominal pain, recurrent pain that is not very sharp, but she feel the uneasiness all the time. And when we check the perispeculum, we see there's a copious discharge is coming. That is sometime we can see the discharge is so copious that it is smearing the outer vaginal wall and the vulva. So the discharge is different from the candidal discharge. It is just watery. It can be green, it can be white, it can be gray, but it has got a very typical fishy odor. So in contrast of the candidal discharge, as we know, candidal discharge is usually cheesy, or it look like in Bengali we say just like a chaler guro, or just like a curd. But in bacterial vaginosis, this discharge is homogeneous and liquid. So But as I said, this is diagnosis is very difficult. Why? Because sometimes both of them can be associated with each other. There can be candidal discharge as well as the bacterial vaginal discharge, and that makes the diagnosis difficult, treatment also difficult, and dilemma of the clinician, what to do, what not to do. So as we discussed, there is no perfect test, though we can do a speculum examination, we can take a swab, and we can check it. So there had been a criteria that is known as EMSL criteria, where we say 3 of the four criteria that we are going to discuss now can make the patient a likely patient. Again, I say likely patient of the bacterial vaginosis. Mind you, it is sometime over-diagnosed and over-treated. But under-treatment is always not I think the over treatment is welcome rather than under treatment too, because this is a chronic disease. So what is the EMSL criteria? There are 4 points. One is pH is, if the pH is more than 4.5. How can we find out the pH? By just seeing by the putting a litmus paper. So litmus paper will tell us whether the medium is acidic or alkaline. Then second is the clue cell in the vaginal fluid. That is very, very pathognomonic of Gardnerella vaginalis. And clue cells are epithelial cells. Those are wrapped by the Gardnerella. Then there is milky homogeneous vaginal discharge, as we have discussed earlier. Then if we put 10% potassium hydroxide or KOH, that is known as Whiff test, there is a typical amine fishy odor that leads to the diagnosis of the bacterial vaginosis. So the bacterial vaginosis, if we have got any 3 of these 4 criteria, we have to label the patient as bacterial vaginosis. Again, after putting KOH, what happened if we put the slide under the microscope? KOH will kill the Gardnerella, but if there is candid infection simultaneous is there, we can see the hyphae of the yeast. So that is in the both way it can diagnose the bacterial vaginosis as well as the candidal infection, and this is a very, very, very easy bedside test, and it can be done easily in any institute or nursing. So how will we diagnose? As we have discussed, there are 4 out of 4, 3 criteria. Already we have discussed pH is greater than 4.5, fishy odor, presence of clue cells. What we have again, see again, this is a higher magnified. There is a epithelial cell that is wrapped all around by the by the small Cocobacillus-like structure. Those are Gardnerella vaginalis, and this typically is known as clue cell and is a pathognomonic of the bacterial vaginosis. Now that was the diagnosis. What is the treatment? So the treatment include many way of giving medical treatment. There can be douching, there can be some application of the ointments. So we will discuss them one by one. So the most common and the mainstay of the treatment is metronidazole. Metronidazole is a very common, very cheap and very easily available drug. Now it has been proven it is safe in the pregnancy. After 14 weeks, we can give any patient. And another drug is clindamycin. Clindamycin is very effective, least used drug, but it is very, very effective for the bacterial vaginosis, again Gardnerella. So metronidazole can be given orally or by vaginal cream. On CT, clindamycin can again given orally or by the vaginal pessary or the ointment available. So the both of them are available in both forms. So now we will discuss treatment. Metronidazole should be given. Here is the twice. It would be thrice a day for 7 days. 500 mg thrice a day. I will again say we should give patient the proper dose and the full dose. Never give patient the half-hearted or low dose or for 3 days or 5 days. I have seen prescription patients are being written 250 mg for 3 days. So this should never be done. Why? Because that can lead to drug resistance and chronic infection. So this is very important. We should give drug in full dose, 500 mg TDS for 7 days. Then metronidazole gel that is available. That can be applied intravaginally once a day at bedtime for 5 days. It can be given for long even. And clindamycin cream or Clingen, it is available in as very many names or pessaries. Then clindamycin cream can be applied 5 gram vaginally, bedtime for 7 days. Alternative regimes can be tinidazole. Tinidazole can be given 2 gram orally for 2 days or 1 gram orally OD for 5 days. Clindamycin again should be given 300 mg twice a day for 7 days, or clindamycin pessary or ovules that can be given at bedtime for 3 consecutive nights, 100 mg dose. So clindamycin ovules can be taken by the patient very easily, and they are very effective, and they can be repeated if patients need. Okay, so but one thing has to be taken very cautiously, because clindamycin can lead to condom failure. So you should tell patient whenever they are using clindamycin, they should be very much alert regarding the rupture of the condom. Secondly, metronidazole, whenever we give, because now many ladies, they take hard drinks, we should tell them not to take alcohol along with metronidazole. Otherwise, it can lead to some untoward reactions. So 7-day treatment of oral metronidazole and 5-day treatment of the gel, as well as clindamycin, 5-day treatment with the oral, or 3-day treatment with the pessary, or 5-day treatment with the vaginal gel is both can be given, though clindamycin has got less metallic effect, less oral side effect, gastrointestinal side effect. So, but metronidazole role is always the first line of the treatment. Another drug is secnidazole. Secnidazole is very, very effective. Secnidazole can be given orally. It is twice a day for 5 days, or it can be given in a ointment form that is non-habit forming and effective. So, what are the current treatment options are? There can be antibiotic, antifungal are usually added along. Why? Because sometimes, as I said, there can be the mixed vaginal infection that is very, very difficult to diagnose, and recurrent rate because of the mixed infection can be high. So that's why we should add these also according to our clinical judgment and patient's need. So now this was the treatment with antibiotics. And so now what are the other options? We had been listened about probiotics in the gut, but probiotics for the vaginal treatment is very, very effective treatment, and now it is being used in India for at least last 15 to 20 years. We have got very good result with the use of probiotic. Why? Because we are giving probiotic that is helping to promote the lactobacilli or the healthy commensal of the vagina. So there are two type of microbes we have already discussed, that is lactic acid bacteria, and another is a bifidobacteria. Bifidobacteria is a gut flora that is a healthy gut commensal, and they are found in fermented food, so that they are helpful for gut health, as well as it has been seen lately they are also helpful for the vaginal health. So how are they working? What are they doing in intestine? In intestine, they are promoting the immune system, as well as they are decreasing the gap, and they are increasing the immunological advance now everything is being related with immunology. So immunological, they are fighting with the bad bacteria. As well as in the vagina, what is happening? They are promoting the growth of the lactobacilli, and they are again modulate the immunologically modulate, and they increase the phagocytosis of the bad cells, as well as they lead to the maturation of the T cell line of the mechanism. So in this way, probiotics can help us to promote the vaginal health and treat the patient with bacterial vaginosis along with the pharmacotherapy. So these probiotics, as we are been discussing, these are because of the antibiotic, what is happening? The commensals are decreasing, good commensals are decreasing. So these probiotics are leading to growth of the this commensals, that is lactobacilli. They lead to the because of the antibiotic, those are disrupting the vaginal flora. Again, probiotic is helping to promote the protecting flora. Antibiotic resistance due to the antibiotic misuse or repeated course can be avoided by use of the probiotic. Then if the patient is not able to take the antibiotic, they can be given probiotic and can be treated very well. Then they are also helping in other way. Why? Because we are helping the patient to maintain ecosystem of the body. So vaginal probiotics are very much, we should be very much clear about the role of the lactobacilli. So we are using probiotics. They establish the protecting role of the lactobacilli. They predominate the vaginal flora with lactobacilli, and they can be used even sometime by the topical methods. So, and clinical trial, those had been done. They are very much easy to do because vagina is an open organ. There can be easy sampling, easy reisolation of the probiotic lactobacilli after application. And they are very well available all over the pharmaco market. So now there had been some study to know how these probiotics are helping, and it has been seen the exogenous strain of lactobacilli have suggested that they can establish a normal vaginal healthy flora back to the normal environment. And these probiotics can also eliminate the bacterial vaginosis. Why? Because they are decreasing the viral load, they are decreasing the bacterial and fungal load, and they are making the patients more adaptive to the normal ecological environment. Again, it has been, there are multiple study that has shown that vaginal microbiota of the IVF patient has been shown that there is high chances of failure rate in the patient with IVF with bacterial vaginosis. And if the probiotics are being added, they return back the vaginal environment to the healthy environment, increasing the success rate of the IVF and live birth rate. Now, different clinical study, those have tried to see how the baby is being cured by probiotic. So there had been multiple study done. One study was done only with the probiotic. They have seen the 21% cure rate in compared to the 0% in the placebo group. But if it is being added with the estrogen in postmenopausal, then the rate of the infection cure is very, very high. That is 88% rather than 22% with only estrogen in the control group in the postmenopausal ladies. Now, daily use of the probiotics as well as metronidazole can cure up to 65% of the patient, in contrast to the only metronidazole. Then vaginal introduction of the cure, this lactobacillus, these probiotics can cure 50% patient by only application of the probiotic. So that has got a good p-value, and that the effect is shown to be clinically effective and good treatment option for the patients. So the conclusion is the use of probiotic is now well established in bacterial vaginosis, and abnormal vaginal microbiota composed has been shown lead to the, because it can lead to so much complication, preterm birth, miscarriage. So patients with pregnancy might be in given bacteria for the prebiotics rather than waiting for these mishaps to be happening. And it is in IVF patient, there are higher chance of conception rate. So this was all. So I would ask you all to consider the prebiotics, probiotics along with the pharmacotherapy for a better patient compliance, better patient treatment, less recurrence rate, and healthy vaginal environment, healthy females, and healthy society. Thank you. That was all from my side. Thank you. Thank you for the patient hearing.
Thank you very much, madam, for this nice and excellent talk. Just give me 1 minute time, ma'am, to check the questions in our dashboard. Yes, ma'am. One question is, what will be the treatment strategy in case of bacterial vaginosis in the all trimester, means early and late case of pregnancy? Is there any difference in the treatment strategy?
In the first trimester,
yes, and
though the
yes,
metronidazole is now proven to be safe in the pregnancy, but still we have got some premonition not using metronidazole orally. So we can give very well metronidazole gel that is very well available in our country, that can be applied at least once at bedtime in all the. There had been some pilot study also regarding this metronidazole in pregnancy, and that has been proven that yes, this works wonderfully. And as we have discussed, that we can add the probiotics along with. So metronidazole gel with probiotics can help patient to get recover from the bacterial vaginosis. And one thing is very important: before starting treatment, we must take a vaginal swab, and it should be at least cultured, or it should be just seen with a whiff test. That is very, very important.
Thank you
In
very much,
second trimester, we can very easily give metronidazole, and oral metronidazole get higher efficacy and higher cure rate. So I would say, with along with metronidazole gel, probiotics, your metronidazole tablets can be given. Those are safe in pregnancy after
Thank
16
you.
weeks.
Thank you very much, ma'am. And one question, ma'am, how long these probiotics can be given along with these antibiotics?
This has been proven. Probiotics can be given for any long of the time, but because of the cost of the therapy, what can we do? We can give the full course of the probiotic, that is thrice a day, for at least, we can give them for at least 45 days, depending on the patient's what is the severity of the case and all. So what the clinically we do, we give it thrice a day for 45 days, and then we can just give a 1 OD dose for maintenance for further 5 to 6 to 5 6 4 6 to 6 weeks. And then patients, you can call patient, you can just re-examine. If she needs, you can tell her. And this works very, very, very efficacious and very good treatment for the bacterial vaginosis, especially recurrent bacterial vaginosis. So probiotics are very helpful for that.
And one question, ma'am, how often in your clinical practice you seen this post-menopausal patients are also affected by this bacterial vaginosis?
Post-menopausal, actually, what is happening, the change of the environment has, vaginal environment is totally changed after the, at least we have seen that after the 3 years of menopause, the vaginal environment is totally become the non-acidic, that become the either neutral or alkaline, depending on the past history of the patient or the comorbidity. Say patient might be having diabetic, uncontrolled diabetic, or there can be some subtle malignancy or something, or patient can have some bad poor hygiene because of her other condition, antibiotic use due to other medical problems. So all these things leads to vaginal environment become very unfriendly, because there is no estrogen, there is no formation of lactobacilli induced lactic acid and alkaline environment, that leads to recurrent infection, burning sensation, So here also we can see the swab, we can take the swab and we can see which organism is growing. And if we give estrogen, it is being seen vaginal epithelial cell return to normal within 2 to 3 weeks if we give estrogen. If we give some creams, estrogen creams are available in the market along with probiotics, and if needed, if they need, we can add the metronidazole, secnidazole, whatever they are comfortable taking, and that helps patient to get improve. Because otherwise, if you don't add estrogen along with, what is happening, the infection is not treated, the recurrent infection is keep on coming, and the patient is suffering, and she is changing doctor from one to another, and she is in very agony, much agony. So nowadays we can also use some antibacterial gels are also available in the market, and those also help these postmenopausal women to have a healthy vaginal environment.
Thank you very much, madam. And just one question, ma'am. In your clinical practice, have you ever come across with this some resistance in metronidazole? Any observation is there?
I have seen few patients, those has been given very improper dose, 250 mg TD, or sometime 2 days patient has taken, patient is okay, doctor said okay, you don't need metallic test, stop. But metronidazole is one drug, the resistance is very, very uncommon. And if we think metronidazole is not working, we can give the clindamycin, or we can give the secnidazole. Secnidazole is very good. I will say secnidazole has got less metallic effect, and it is also very good. Though potency wise, it is less efficacious than metrogyl, but still secnidazole is very, very easily available and very nice acting drug, and that compliance of the patient is very good with secnidazole that I have seen. But metrogyl resistance is not that common, I would again say.
Thank you very much, ma'am, for this nice discussion on this very important topic. And I could not find any other question right now, ma'am. So if we get any, we'll obviously forward it to you. So thank you very much once again for your valuable time on our platform, the knowledge sharing platform, Shield Connect. And in future also, we will be very happy to organize such kind of nice medical session with you. So thank you very much, madam, once again.
Thank you.
Have a good
Pleasure
day,
was
ma'am.
mine.